Greetings and salutations, all my friends. Hello and welcome to Approach to the Abdominal Examination. Dr. Ryan here. And guess what? You can see me now. Maybe I can't see you, but in all my videos previously, I've been presenting much like John Cena, you can't see me, but now you can see me. So I'm quite excited, and I pray that you and your family are well. Let's get stuck in, guys. Today we're talking about an approach to abdominal history taking, where we're going to focus mainly on the GI systemic inquiry. Then we're going to get into an examination approach for the abdominal system, which follows the time-honored sequence of inspection, palpation, percussion, auscultation, inspection, palpation, percussion, auscultation. Then we're going to talk a little bit about how to investigate patients who have disease of the gastrointestinal system. So as always, here's my handy history-taking template, which goes according to my kind of time-honored mnemonic, which is perhaps salt makes good food so tantalizingly tasty. So P stands for presenting complaint, S systemic inquiry, M for the medical history, G for the gynecological history, if relevant, F for the family history, SO for social and occupational history respectively, T for third-party information, and T for travel history. But today we're going to speak specifically to the systemic inquiry as it relates to the gastrointestinal system. Let's go. So when asking about a GI systemic inquiry, you have to inquire from the patient, are you troubled by indigestion, which may speak to dyspepsia, right? Which could be coming from peptic ulcer disease or just gastritis. Then you ask, do you have heartburn and associated water brash, any difficulty swallowing, and any pain with swallowing? So difficulty swallowing, we know, is dysphagia versus pain on swallowing, which is odynophagia. Have you had any nausea and vomiting? At the same time, you can ask, have you been vomiting any blood? So you ask about hematemesis. Have you had any pain or discomfort in your abdomen? Any abdominal bloating or distension? Has your bowel habit changed recently? Right? And how many bowel motions do you usually pass per week? And they be trying to define if the patient has constipation or diarrhea. Have you lost any control of your bowels, speaking to fecal incontinence? Have you seen any blood in your bowel motions? Now, there we speak to bright red blood, more likely rectal pathology, hematochezia, dark blood indicating blood that has already been digested by the gastric acid. So it must be coming from above the ligament of Treitz, usually signifying an upper GI bleed. Have your bowel motions been black? That is Menina stools. Have you lost weight recently? Have your eyes or skin ever been yellow, speaking to jaundice? Have you ever had hepatitis, peptic ulceration, colitis, or bowel cancer? Those are significant relevance on your medical history as pertains to your GI system. And tell me about your diet recently. Okay, so when the patient complains of abdominal pain, it's nice to visualize where the pain could be coming from, viscerally speaking. So we know that there are three embryological regions of the gut: the foregut, the midgut, the hindgut. So if it's pain coming from the foregut, it usually localizes to the epigastric area, as seen in blue, right? If it is coming from the midgut, then it probably localizes to the periumbilical area in pink. And if from the hindgut, it localizes to the suprapubic area in green, all right? I just want to use this to define possible causes of abdominal pain based on specific characteristics. So the four big headings we have is peptic ulcer, biliary colic, acute pancreatitis, and renal colic. So peptic ulcer, the site is usually the epigastrium, has gradual onset, very gnawing, persistent kind of character, radiates to the back. The timing is that it probably goes into remission for weeks or months, right? And occurs specifically during the night and when the patient is hungry. The duration is from half to 2 hours. Exacerbating factors for the pain of peptic ulcer are stress, spicy foods, alcohol, non-steroidals. Relieving factors of food, antacids, and vomiting, and severity can vary from mild to moderate. Remember that peptic ulcer can, of course, complicate, right, with GI bleeds, and with perforation giving rise to Peritonitis. Biliary colic, on the other hand, often sits in the epigastrium or right hypochondrium. The onset is rapidly increasing. It's a constant character and radiates below the right scapula. In terms of frequency or periodicity, you are able to enumerate the attacks. It's really unpredictable. Duration can last anywhere from 4 to 24 hours. Exacerbating factors is that the patient with biliary colic is unable to eat during bouts. Severity is severe. With acute pancreatitis, the pain usually localizes to the epigastrium, while the left hypochondrium has a sudden onset. The character is constant and radiates into the back. Usually occurs after binge drinking. Duration is about over 24 hours. And exacerbating factors, I beg your pardon, is alcohol, and the patient is unable to eat during those bouts. It's relieved by sitting upright, and severity is severe. Versus renal colic, which is the classic loin to groin pain. All right. Some non-alimentary causes of abdominal pain, relatively common: myocardial infarct. Oh dear. Right. And here we have epigastric pain without tenderness, angor-enemy, which is a fancy way of saying feeling of impending doom. Oh dear. Hypertension and cardiac arrhythmias. Other things which can masquerade with abdominal pain is dissecting aortic aneurysm, which is it classically manifests as tearing interscapular pain, but clues is asymmetry of the femoral pulses and the hypotension. Acute vertebral collapse, cord compression, pleurisy, herpes zoster, DKA, salpingitis, or tubal pregnancy, torsion of the testes can all present with abdominal pain that is not coming from your bowel. Examples of drug-induced GI conditions, all not that uncommon. Weight gain as a result of corticosteroids. Corticosteroids are not innocuous drugs. They cause a whole range of side effects, including posterior subcapsular cataract, gastric ulcer, suppression of the HPA axis, hypertension, hyperglycemia, ischemic necrosis of the femoral head with osteoporosis, neutropenia with infection, psychosis, predisposing to diabetes, etc. Right. Dyspepsia and GI bleeds can be attributed to the common use of non-steroidals and aspirin. Many drugs cause nausea, especially your SSRIs. In terms of diarrhea, what causes pseudomembranous colitis are your antibiotics, right, and proton pump inhibitors. Alrighty, especially watch out for C. diff there. Constipation caused by opioids. Jaundice, and we have hepatitis. Like we know that paracetamol in overdose quantities can cause fulminating hepatitis, as can pyrazinamide, rifampicin, isoniazid, your TB drugs. Cholestatic picture can be caused by flucloxacillin, comoxiclav. Watch out, that's commonly prescribed augmentin right there, causing cholestatic jaundice, chlorpromazine. Liver fibrosis on the back of methotrexate. Here's some classification of the causes of dysphagia. So with mechanical obstruction, we know the classic description is, doc, you know what, I have difficulty for swallowing solids more than liquids. But if there's equal difficulty with swallowing solids and liquids, that points to a motility disorder. So as you can see, as outlined in the table, common causes of mechanical obstruction can be from intrinsic, which means from within the esophagus, or from outside the esophagus, so-called extrinsic. And the most common intrinsic causes of mechanical obstruction of the esophagus are carcinoma of the esophagus or gastric cardia, reflux esophagitis with stricture formation. Then you get the somewhat less common causes like eosinophilic esophagitis, pharyngeal or esophageal web, Schatzky ring, etc. If it's extrinsic, meaning that the cause of obstruction is outside the esophagus, we're thinking about goiter with retrosternal extension, mediastinal tumors, etc. If it's a motility disorder and that swallowing solids and liquids are equally difficult, thinking about achalasia, diffuse esophageal spasm, and of course scleroderma. If it's oropharyngeal dysphagia, and the tip-off here is that the patient frequently has episodes of aspiration and fluid regurgitation into the nose, then you're thinking about a Zenker's diverticulum. They typically have very, very bad breath. Ooh, very bad breath. You can smell the patient when they get into the waiting room. And neurological disease in the way of bulbar or cerebral palsy, often in the setting of patients who stroked out, myasthenia gravis, polymyositis, myotonic dystrophy. Those often also cause neck flexion weakness. Okay, just a few more tables, guys, and this is quite dry before we get into the actual topic for today. But GI and so-called alarm features include persistent vomiting, dysphagia, fever, weight loss, GI bleeding, anemia, painless, watery, or high-volume diarrhea, and nocturnal symptoms which wake up the patient from their sleep. And risk factors for viral hepatitis, you must inquire from your history, intravenous drug use, tattoos, foreign travel, blood transfusions, MSM, etc. Okay. Ta-da! Here we go. Abdominal examination. Fasten your seatbelts, everybody. Hey. So this is a bird's eye view of the examination of the abdominal system. So you start off here, right at the bottom. We talk about. So it's always good to just step back and look from the edge of the bed. Just observe the patient for their body mass in terms of obesity or weight loss, cachexia. Look at the state of hydration, the patient's pyrexial, if they're in obvious distress or pain, and any obvious muscle wasting. Then when you get to the hands, you're looking for clubbing and koinonia, which speaks to iron deficiency mostly. Signs of liver disease we'll be talking about, it's like pneumonia, palmerythema, Dupuytren's contractures, etc. Then as you go up on the arm, you want to check the pulse and the blood pressure. When you get to the face, you're looking for pallor and jaundice and spiroangiomata and percussion, which speaks to alcoholic disease, right? In the mouth, you look for angular stomatitis and glossitis. In the neck, for lymphadenopathy, right? Abdomen, we're going to go through this, right? Inspection, palpation, percussion, auscultation. You have to comment on scars, swellings, distended veins on inspection, on palpation. Check for your visceral megaly, your hepatosplenomegaly, any obvious masses. You're going to pull out those kidneys, percuss that bladder, and check for tenderness. When you're going to percuss, we're checking for shifting dullness or a fluid fill for ascites, auscultation of your bowel sounds and your bruise. You also want to quickly assess the groins for any hernias or lymphadenopathy, perianal or genital area. You might want to do a PR exam if it's indicated, as scrotal examination as well. In the legs, you just check for edema and pyoderma gangrenosum. Alrighty. Starting off, you want to introduce yourself to the patient as always. Remember, by convention, we always remain on the right side of the patient. Ensure the patient is lying flat in a supine position with a nice pillow for their head. The hands of the patient are to be kept at their side at all times. The abdomen is exposed from the inframammary region to just above the pubic symphysis, all right? And you just want to quickly inspect from head to toe. Like we said, there may be some clues for diagnosis, like chronic liver disease. We're going to look specifically at the stigmata of chronic liver disease in a subsequent slide. Look for features of chronic kidney disease, nephrotic syndrome. Usually the patient is grossly edematous, has anasaka, especially periorbital edema, acute glomerulonephritis as well. Do your urine dipstick. Look for those, the blood that's there, all right? Send it off for casts as well. In cases of hereditary hemolytic anemia, the patient may have frontal and parietal bossing, mongoloid facies, so you have all these clues that you want to pick up on. This is taken from Talley and O'Connor, showing us the general positioning of a patient when you're going to approach examination of the abdominal system. And we know we can split, anatomically speaking, we can split the abdomen into either 4 quadrants or into 9 particular regions. Right, so looking at this beautiful diagram here, on the top, region 1 is the right hypochondrium, number 3 is the left hypochondrium, and number 2 in between is epigastrium. Right, region number 4 is the right lumbar region, number 6 is the left lumbar region, sandwiched between them, number 5 is the umbilical region, area 7 is the right iliac fossa, number 9 is the left iliac fossa, and number 8 the hypogastrium. Alrighty. So when you inspect the abdomen, you want to check the shape of the abdomen, and you want to comment on whether it's normal, distended, or shrunken, something we term scaphoid abdomen. If distended, you want to determine whether that distension is generalized or localized, right? So is it localized to the epigastrium, the left or right hypochondrium, the iliac fossa, or is it central? Then you want to inspect movement of the abdomen. So ask the patient to gently take a deep breath in and out, and you want to look from either the leg or the head end to see if movement is equal on all sides. Sometimes you want to also just get down on it, boom, boom, bang, to look at the level of the patient's abdomen if there are any particular masses that are obvious. Visible peristalsis must be noted. Visible pulsation in the epigastrium can be seen, but you can also feel it later on. The umbilicus may be inverted or everted. If that be the case, you want to comment on those things. If you have visible or engorged veins present, you want to mention the site in terms of whether it's the central part, the flank, above or below the umbilicus, or around the umbilicus. You want to see the flow of the veins. It's upwards, downwards, or away from the umbilicus. We'll talk about that. If there are stria present on the abdomen, you mentioned the site, the color, the size, and whether vertical or horizontal. Remember, livid, wide stria, right, usually probably indicates Cushing syndrome, or it's part of the stigmata that you want to expect with Cushing syndrome, right? However, stria can also be caused by rapid weight loss recently and a whole lot of other causes. If there are any scar marks like surgery or from surgery or trauma, you want to mention that. If there's a fistula, usually the result of Crohn's disease or a stoma, you want to mention that. Pigmentation must be noted. It could be linea, not lingua. Lingua is a tongue, sorry about that. Linea nigra from below the umbilicus, or erythema ab igne. Any obvious swellings or masses, you want to note the sites and whether it's intra or extra abdominal. And the way you tell if the mass is intra or extra abdominal is ask the patient to contract the abdominal muscles or to raise the leg. That's going to cause contraction of the skeletal muscles of the abdomen. And indeed, if it is extra abdominal, it will become more apparent. But if it's intra abdominal, it won't. Right? Campbell-De Morgan spots, if they are there, comment on them, and the groin for hernias, pubic hair, and genitalia. This is once again taken from Talley and O'Connor, demonstrating for us some locations of anterior abdominal wall veins. So one, we can see veins over the costal margin, which if you see it is not really of much clinical significance. Two is the infamous caput medusae, which happens in the setting of portal hypertension. Number three is inferior vena cava obstruction. Now, when you see this, remember you want to ascertain the direction of the flow of blood in that vein. So as we see in these different figures, in figure A, 2 fingers are placed firmly on the vein. Then as in figure B, the second finger is moved along the vein to empty it of blood and to keep it occluded. And in C, the second finger is removed, but the vein does not refill. And then you want to ascertain, at repeat testing, do the same thing again, then remove your first finger instead of your second finger and check in which direction flow occurs. Now remember that you got to test veins below the umbilicus, right? And in portal hypertension with the caput medusae, these veins will flow towards the legs. But if it's IVC obstruction, the veins will flow towards the head. Alrighty. So here are the stigmata of chronic liver disease, as we can see depicted in this beautiful picture from McLeod's. Alright, so in the hands you look for leukonoikia, which is white nails because of hypoalbuminemia. You get palmar erythema and clubbing. You're going to note these in the hands, right? In the chest, you may have gynecomastia in men or breast atrophy in women. Note the jaundice when you go up to the eyes, right? In the upper half of the body, in the distribution of the superior vena cava, above the umbilicus, you want to look for spina angiomata, right? In the abdomen, you can look for hepatosplenomegaly, but the liver may be small if cirrhotic. And you look for dilated collateral vessels around the umbilicus, which is what we affectionately term caput medusae, right? Testicular atrophy, but obviously you ask the patient first before you just go in there and examine for testicular atrophy. Legs, edema and hair loss, and in general, you check for skin pigmentation, loss of body hair, and bruising. All right, signs of hepatic failure are the following. So the patient will have acidexis. That speaks, and we're going to speak to the different grades of encephalopathy. Right, fetal hepaticus, which is a stale, mousy smell of volatile amine dimethyl sulfide on the breath. You look at the flapping tremor or acidexis, like we said, with the hands dorsiflex, right? So the way you do it is you cock the wrists up, you separate the fingers, right? And the classic motion is to and fro movements, right, at the wrist joint, right? The mental state speaks to encephalopathy, varies from drowsiness with a day-night pattern reversed through to confusion, disorientation to coma. We'll speak about that. And the late neurological features include spasticity and extension of the arms and legs and extensor plantar responses. Alrighty. This is the grading of hepatic encephalopathy, which is termed the West Haven grading. Alright, so the 0, 1, 2, 3, and 4. So in 0, there's no change in personality or behavior and there's no acidexis. Right, but in stage 1, there's impaired concentration and attention span. Patient has sleep disturbance, slurred speech, euphoria, or depression. Acidexis is present in stage 1. Stage 2 is a progression of this, right? To lethargy, drowsiness, apathy or aggression, disorientation, inappropriate behavior, slurred speech. Stage 3 is further progression to confusion, disorientation, bizarre behavior, drowsiness or stupor. Acidexis usually absent. In stage 4, the patient is comatose with no response to voice commands and minimal or absent response to painful stimuli. This is the grossly distended abdomen. Look at this thing. But this is ascites already. And here I just included this just to show us some of the common abdominal incisions already, so you can have a look at that. Let's move on to palpation of the abdomen. So first you want to ask the patient if there's any particular pain, because the last thing you want to do is cause your patient pain with palpation. And if there is indeed pain somewhere, you want to examine that particular portion of the abdomen last. Ensure that your hands are nice and warm. Place the palms gently on the abdomen. Rather than the tips of your fingers, you want to place your palms on the abdomen, keeping the hand flat on the abdominal wall with gentle flexion of the metacarpophalangeal joints. Alrighty. And during palpation, always look at the patient's face to ascertain whether they wince in pain. Alright. So firstly, you want to perform superficial palpation. So feel just superficially for any rigidity or any mass. Also note the infamous Sister Mary Joseph nodule, which is a hard periumbilical lymph node, highly suggestive of metastases coming from the pelvic or gastrointestinal tract primary tumor. The other one you want to look out for is Trousseau's node, which is a very, or what we call Virchow's node, which is a very hard left supraclavicular node, which if present speaks to a stomach or a gastric malignancy. Right? You want to also palpate for tenderness. With regard to the liver, we're going to look at a diagram just now, but you want to start from the right iliac fossa and ask the patient to breathe slowly in and out, and then press and proceed while the patient is in inspiration and observe the patient's face. If the liver is indeed palpable, there are a lot of points we need to note. The size, so we're going to measure the size in centimeters with a tape from the costal margin in the midclavicular line. If the left lobe is enlarged, you measure from the left xiphoid process. Then you want to note the margin, whether it's round, smooth, or sharp, the surface, whether it's smooth or irregular. Check if the liver is tender and comment on that. Consistency, whether it's soft, firm, or hard. I'm going to percuss out the upper border of the liver by percussion, and that's normally located in the fifth right intercostal space in the midclavicular line. And you auscultate over the liver for a bruit or a rub, which is often forgotten. Remember, you're going to get a bruit in hepatocellular carcinoma specifically. And also note the pulsatile liver, which happens in the setting of tricuspid regurgitation. All right. Regarding the spleen, you keep your left hand in the lowermost part of the left side of the chest with minimal pressure. And remember that in adults, the spleen enlarges inferomedially. So you want to start all the way down the right iliac fossa. Ask the patient to breathe in and out gently. If the spleen is not felt, you turn and you're going to feel progressively upwards. And we're going to look at a beautiful picture just now. But if the spleen is not felt, you turn the patient halfway towards the right and palpate again. If the spleen is felt, you want to note the size measuring in centimeters along its long axis from the costal margin in the anterior axillary line towards the right iliac fossa, and also from the costal margin to the left midclavicular line. You want to feel that splenic notch and check if you can actually get above the spleen. Percuss over the spleen and continue up to the left lower part of the chest to see continuation of splenic down. This is also this area called trope space, and if there's dullness in trope space, then that also indicates a big spleen. You want to palpate both the right and left kidneys by ballotment. Just palpate and check if you can feel a gallbladder. Remember Courvoisier's law. Courvoisier's law states that in the presence of jaundice, a palpable gallbladder is unlikely due to inflammation or cholecystitis. It probably indicates a malignancy of the biliary tract. And feel for any masses, feel for the para-aortic lymph nodes with your fingertips. Right, palpate for hernial orifices. So ask the patient to cough. Then you want to see, then palpate the testes with permission, of course. And finally, a PR exam if it is clinically indicated. All right, so these are the different palpable abnormalities we have in the abdomen. So epigastric mass speaks to gastric cancer, pancreatic cancer, aortic aneurysm, hepatosplenomegaly. Remember, a palpable liver is not always enlarged, and that's the value of determining the span of the liver. Always percuss out that upper border and check it for a palpable gallbladder. Generalized distension, we speak about the infamous brother F's, lots of F's. F for fat, which speaks to obesity. F for fluid, speaking to ascites. F for flatus, which speaks to obstruction or ileus. F for feces, speaking to constipation. F for fetus, pregnancy. If there's a mass in the right iliac fossa, thinking about cecal cancer or Crohn's disease, one appendiceal abscess. Right, if there's a left upper quadrant mass, you think, is it the spleen? Then you ask yourself a couple of questions. How's the edge? Can I get above it? If you can't, then it's more likely the spleen. Does it move towards the right iliac fossa on aspiration? Does it have a dull overlying percussion note? Is there dullness in trope space? Right? Is there a notch? And then this is as opposed to the kidney, which is more rounded. You can get above it. A kidney moves inferiorly on inspiration, is resonant to percussion, and is palatal. Right? Then is the mass tender to palpation? And if tender, you're going to ascertain, is the patient peritonitic? Ooh, get the surgeons involved there. Is there guarding? Is there rebound? Are there absent bowel sounds? Is it rigid? You're thinking about obstruction in a patient who complains of constipation with vomiting. The abdomen is grossly distended. You have tinkling, tinkling, tinkling bowel sounds, and there's visible peristalsis. If there's a big old mass in the left iliac fossa, you're thinking to yourself, is this sigmoid colon cancer? Is the patient just constipated? Is it a diverticular mass? Here I just included examples of palpable masses which may be physiological rather than pathological, including the aorta, the liver edge, the lower pole of the right kidney, and small lymph nodes. That's on the right hand side. On the left hand side, it could be heart feces sitting in this large bowel. It could be just a rectus abdominis and its tendinous insertions, a normal colon, or a distended bladder. So this demonstration the proper technique for assessing hepatomegaly, right? So you start down in the right iliac fossa and you come progressively upwards. You palpate, while flexing at the metacarpophalangeal joints during inspiration, okay? And this is just percussing out the upper border of the liver, right? Which we know to be normally in the right fifth intercostal space mid-clavicular line, and you measure the span of the liver. Remember, a normal liver span is anywhere between 7 to 12 centimeters. Here, this is showing the proper technique for assessing the spleen. So we said we start in the right iliac fossa and we work our way diagonally upwards the abdomen to finish off at the left costal margin. And as demonstrated, see, your left hand, right, will support the patient's side, while your right hand feels progressively upwards coming from the right iliac fossa. And the reason we do this is to reduce skin resistance. If the spleen is not palpable when the patient is flat, he or she should be rolled towards the examiner as depicted in picture D. Thank you. This is from Talley and O'Connor. Okay, so here I just want to note the patterns of progressive enlargement of the liver and spleen. So the liver, as you know, moves inferiorly, and in adults the spleen moves inferomedially. All right. So causes of hepatomegaly, this is the way McLeod does it. So we speak about 4 big headings: chronic parenchymal liver disease, malignancy, right heart failure, hematological disorders, and rarities, right? But I just want to draw attention to lymphoma, myelofibrosis, leukemia as one of the main players causing a big liver from the hematological perspective. If it's chronic liver parenchymal disease, thinking viral hepatitis, autoimmune hepatitis, hepatic steatosis, which is common among diabetics with NAFLD and NASH, alcoholic liver disease. Don't forget malignancy, which can be a primary hepatocellular issue or could be a secondary metastatic deposit. Okay, causes of splenomegaly are split into these big 5 headings: note hematological disorders, and then we have lymphoma and lymphatic leukemias, myeloproliferative diseases like polycythemia rubra vera and myelofibrosis, portal hypertension as well, but they often keeps company with ascites and Kappa-Medusae, etc. Infections can cause splenomegaly, the likes of malaria and kala azar, which would cause massive splenomegaly, bacterial endocarditis, brucellosis, TB, salmonellosis, glandular fever, rheum conditions like Felty's syndrome, which happens in the setting of rheumatoid arthritis, systemic lupus erythematosus, the wolf, rarities like sarcoidosis, amyloidosis, and glycogen storage diseases. What causes both hepatosplenomegaly? Liver and spleen both big. What causes that? Lymphoma can cause it. Myeloproliferative diseases can cause it. Cirrhosis with portal hypertension. Don't forget your infiltrative disorders like amyloidosis, sarcoidosis, glycogen storage diseases. So my easy way to remember causes of hepatomegaly are the 3 C's and the 3 I's. So the first C, speaking to carcinomatosis. Remember, cancer in the liver can be a primary issue in the way of hepatocellular carcinoma, or it could be hematological malignancy in the way of lymphoma, leukemia, and of course it could be secondaries coming from the bowel mainly. The second C is for congestive cardiac failure, often right-sided heart failure. Cirrhosis can also cause it earlier on. Those you have 3 C's. And 3 I's, the first one being infective in the way of hepatitis A to E, cytomegalovirus, Epstein-Barr virus. Don't forget liver abscess can also cause hepatomegaly. Immune issues in the way of autoimmune hepatitis, primary biliary cirrhosis, primary sclerosing cholangitis, infiltrative issues in the way of sarcoid and amyloid. Let's move on to percussion. Percussion. Usually a light percussion is done, and the note will give you a normal tympanic sound. You want to ascertain the area of liver and splenic dullness, right? And if there's suspicion of ascites, you check your shifting dullness. We'll talk about that. And if there's obviously, if there's tense ascites, you want to ascertain the fluid flow. So the way we do it, guys, is the patient is lying supine, right? And we know that because of gravity, any ascites in there is collected from the flanks upwards, right? So what you're going to do is you're going to start percussing in the midline and move laterally away from you until you encounter dullness. Then you're going to ask the patient to turn toward you, wait for about 20 to 30 seconds. The fluid will redistribute because of gravity. And the area that was initially dull now becomes resonant. right? That confirms shifting downwards, and that's the technique, right? So you start from the midline, progress out until you get downwards, then you turn the patient towards you, and that area that was initially dull now becomes resonant, alrighty? If there's 10 societies, you elicit a fluid thrill as depicted. So here, there's a beautiful table from McLeod outlining the differences between a palpable spleen and a left kidney. And so we've been through this, but let's just quickly rehash this. So the distinguishing feature here is that the spleen is usually smooth and regular in shape. So if it's smooth and regular, the spleen is more likely. However, watch out for polycystic kidneys as well. If the mass descends in inspiration, it's both of them do so, right? If you're able to feel deep to the mass, it's most likely the spleen. If there's a palpable notch on the medial surface, yes, it's most likely the spleen. If there's bilateral masses palpable, most likely the kidneys, especially in the setting of adult onset polycystic kidney disease. If the percussion node is resonant overlying it, sometimes in the kidney, not always, but if it is indeed there, it's more likely the kidney than the spleen. If the mass extends beyond the midline, sometimes it's the spleen, which we said in adults goes inferior-medially, but in kids just inferiorly. But the mass, if it's a kidney, will never extend beyond the midline, with the exception of a horseshoe kidney. If there's ascites, we want to do an acidic tap and we ascertain what we call the serum albumin acidic gradient. We sag it. Now remember that the sag is not a ratio, it's a difference. It's the serum albumin minus the acidic fluid albumin. If that result is above 11, it speaks to portal hypertension, right? And the causes of high sag ascites are cirrhosis, alcoholic hepatitis, Budd-Chiari syndrome, which is otherwise known as hepatic vein thrombosis, together with its friend veno-occlusive disease, fulminant hepatic failure, congestive heart failure, congestive pericarditis, and the setting of cardiac ascites. But if the sag, which we said was the difference between the serum albumin and the acidic fluid albumin, is less than 11, it speaks to the cause not being due to some degree of portal hypertension, so-called exudative cause of the ascites. The main culprits there are peritoneal carcinomatosis, tuberculosis, pancreatic ascites, sometimes nephrotic syndrome, especially after you leave your Lasix. Then you want to auscultate for bowel sounds and ask yourself, are they normal or absent in the setting of paralytic ileus? Check your potassium, guys, because that causes ileus. And you auscultate over the liver for hepatic bruit, which, if present, probably indicates underlying hepatocellular carcinoma. Listen for the renal bruit. Where do you listen? 2 centimeters above the umbilicus to the right of the midline, and of course to the left as well for the left kidney. Listen for the bruit of aortic aneurysm. Listen for the splenic rub, which is very rare. Listen for the venous hum. Venous hum is heard between the xiphisternum and the umbilicus. It is a low-pitched, very soft sound. It indicates portal hypertension due to a large volume of blood in the umbilical or the paraumbilical vein sitting in the falciform ligament due to a polysystemic shunt. Remember the infamous Cuvier-Baumgarten syndrome, right? Is basically a combination of a venous hum with prominent abdominal wall veins. Okay, so here we're looking at investigations in gastrointestinal and hepatobiliary disease. So the radiological investigations, okay, as mentioned, do a chest X-ray if you're thinking about a perforated viscus, in which case you're going to have air under the diaphragm. And if you suspect pneumonia or pleural effusion, it's good to do a chest X-ray. Abdominal X-ray if you suspect intestinal obstruction. We're going to look at a couple of examples. If you suspect perforation or renal colic, look for air fluid levels, and also you can see urinary tract stones in 10%. A barium meal is used if you suspect that if the patient has dysphagia and dyspepsia, if gastroscopy or upper GI scope is not possible, and of course if the patient has esophageal obstruction. Endoscopy is preferable, especially if the patient had previous GI surgery. Then we also have indications for, as noted, for small bowel barium follow-through or large bowel barium enema or CT coronography. Upper abdominal ultrasounds. We do upper abdominal ultrasounds indicated if you're thinking about biliary colic or jaundice or pancreatitis or malignancy. If you want to see gallstones, liver mets, cholestasis, pancreatic calcification, subpharetic abscess. Abdominal CT is indicated in the acute abdomen. In suspected pancreatic or renal mass, if you want to stage a tumor, or if you're thinking about abdominal aortic aneurysm, to confirm the dimensions and the characteristics of it, which will obviously inform possibility of surgery. Then you want to confirm or exclude metastatic disease and a leaking aortic aneurysm, right? MRCP is reserved in cases of obstructive jaundice where you're thinking about a PSC, the string of beads, right? And also in acute and chronic pancreatitis. Pelvic ultrasound if you're thinking of some, gynecological pathology. The invasive investigations upper GI scope in patients who present with dysphagia, dyspepsia, GI bleeding, gastric ulcer, malabsorption, right? A gastric or duodenal biopsies are obviously taken and are useful. Other investigations include lower GI scope in the patient with rectal bleeding, also bowel habit, unexplained GI bleeding. You're able to biopsy lesions and remove polyps. And we also have other investigations like a video capsule endoscopy when the patient has unexplained GI bleeding, small bowel disease, vascular malformations, inflammatory bowel disease. ARCP, right, is both, it informs the diagnosis and, of course, it is therapeutic. Right, so in the setting of obstructive jaundice, acute and chronic pancreatitis, it has a diagnostic and therapeutic role. It can be used to stent strictures and remove stones. Laparoscopy, those indications as noted. Ultrasound or CT-guided aspiration, cytology, and biopsy for liver mets, intra-abdominal or retroperitoneal tumors, and of course liver biopsy if there's parenchymal disease of the liver, and we can undertake this tissue biopsy by percutaneous, transjugular, or laparoscopic route. Right, pancreatic function tests, especially in the setting of chronic pancreatitis, include stool elastase and the pancreaoral test. Okay, here's a beautiful picture showing us acute pancreatitis and showing the gray Turner sign out there on the flank, right, and the Cullen sign, which is a bruising around the umbilicus. So here we can see A under the diaphragm here, which speaks to a perforated duodenal ulcer or a perforated hollow viscus, right? Here we have dilated small bowel, which is due to acute intestinal obstruction. Here is dilated large bowel. Look at this thing. It's massive, man. This is toxic megacolon on the left, and on the right is a so-called coffee bean sign. Looks like a coffee bean, huh? And that's dilated loop of large bowel due to our beloved sigmoid volvulus. Here's ultrasound showing us this beautiful posterior acoustic shadowing we have in the patient who has gallstones. And here is just a snippet of upper GI scope demonstrating a gastric ulcer here. Right, gastric ulcer. See this big old erosion. And here we have gastric varices, that look like little worms in the setting of portal hypertension. Here's a colon demonstrating a vicious colon cancer. Alrighty, so guys, as always, I just want to encourage you from the Word of God. I just want to speak a little bit about wisdom. I'm sure all of us desire to have wisdom and to grow in that respect. The book of James chapter 1 verse 5 says, "If any of you requires wisdom, let him ask of the Lord, who gives generously to all, it shall be given unto him." And Proverbs chapter 9 verse 10 tells us, "For the fear of the Lord is the beginning of wisdom, and knowledge of the Holy One is understanding." And I pray that we will pursue God and want to know him actively and intimately. And so we have the Holy Spirit who counsels us and brings us wisdom in any particular situation or circumstance. God bless you. Here are my references. Looking forward to seeing you again with another informative video on my channel, Internal Medicine Algorithms and Mnemonics. Please like, share, and subscribe. This is Ryan signing off.